Ever since I was a kid, I've been fascinated by the heart. And you could ask why. Well, one obvious reason is it's beating 24/7. And it's very impressive. Over the course of a lifetime, it could beat 3 billion times, pumping hundreds of millions of liters of blood. It's very impressive. But what happens when the heart stops? Well, of course, it's going to stop at some stage. We all die eventually. But what happens if it stops beating when you're 20 years of age? And many of you have seen these elite athletes playing soccer, football, hockey, and collapse on the field. And in these instances, they're usually suffering from sudden cardiac arrest. So what is sudden cardiac arrest? Well, in order to revive the person, we have to use an automated external defibrillator, or else the heart won't start beating again. And of course, these are distributed now in most buildings, hockey rinks, etc. And when they apply a jolt of electricity, the heart starts beating again. However, the person has been revived, but they have not been cured. So what is this phenomenon that we're talking about? Well, sudden cardiac arrest, you might think of it as being a heart attack, but it's nothing at all like a heart attack. And maybe a good analogy would be heart attack is like plumbers are to electricians. Now, the plumbers represent, or the plumbing problems represent a heart attack, and the coronary vessels get blocked with a clot or some fatty tissue that you're aware of. But sudden cardiac arrest is an electrical chaotic event, very hard to detect. So in a normal ECG pattern, which looks something like this, we can see the characteristic behavior of normal excitation and relaxation. When the heart goes into sudden cardiac arrest, the ECG, the electrocardiogram, looks like this. This is myocardial fibrillation, and we can only last about 2 or 3 minutes once we go into this stage. We have to be revived. Now, what causes this? Well, we know that there are a variety of different mutations that we were born with. But we're talking, for example, a kid, a young adult, 20 years of age, who was born with this mutation. And yet, the problem never occurred until they were 20, 25, 30 years of age. And so what has to happen is not only do they carry the mutation, and most often they're not even aware that they have this mutation, but a confluence of other events, perhaps exercise, and perhaps some drugs they're taking, over-the-counter medications. A variety of different things have to happen at the same time, which trigger the sudden cardiac arrest and result in this myocardial fibrillation. Now, these images that you can see on YouTube, they're quite devastating, but honestly, the impact really wasn't felt by me until about 8 years ago, and that was when Bernie Dietrich was quarterback at Simon Fraser University. And this kid, he came from Austria, of all places, to play football. This was his dream, to play football. And he became the starting quarterback. He became a star quarterback. And in the middle of the football season, he had sudden cardiac arrest, and he died, age of 21. Very tragic. But it was this event that really struck me. I mean, I had read, and all of you have seen these kinds of events, but this was more personal. I mean, it was felt across the campus. And in my mind, it sort of shifted what I was thinking about how to apply my research. And so we started investigating this. We can call these events the perfect electrical assassin. And the reason being is that often the first symptom is death. These people are unaware that they're carrying mutation which could lead to their demise. The second thing is, on autopsy, there are no visible signs of how the person died. So it makes it incredibly difficult. So it's like a ninja, I guess, in a sense, in that it creeps up, attacks, and leaves the scene. Very difficult to deal with, very difficult to predict. So the question is, can these new tools that I'll talk about in personalized medicine actually address these questions? Can we predict who's at risk? Can we prevent them from actually having sudden cardiac arrest? Can we detect which mutations are the most serious? And my answer to this question is yes. And there have been many techniques that have developed, but in the last 10 years, particularly in the last 5, 2 transformative techniques have completely revolutionized medicine. The first one is the ability to reprogram adult cells into stem cells. And the second is to genome edit these cells or any other kind of cells using genome editing programs, and you're probably most familiar with the protocol known as CRISPR. It's in the news almost every day. These 2 techniques collectively can be used to actually impinge and improve the response that we just talked about, improving the case of sudden cardiac arrest and other problems that I'll talk about. So what are these? Well, first of all, the technique of reprogramming adult cells, and they could be skin cells, fat cells, blood cells, into stem cells, embryonic stem cells that have the capability of becoming anything, was developed by Shinya Yamanaka in Japan. And what he developed was the discovery, after many, many years of incredibly difficult work, of the so-called Yamanaka factors. There's 4 of them, and they're transcription factors. And when these factors are placed into the adult cells, they cause the entire cell to reprogram. And over the course of about a month, these cells have completely been transformed from adult cells into pluripotent stem cells. Now, why is this important? Is because what we and other people do, we now take these pluripotent stem cells that came from the patient or they came from the donor, carrying their genomic information, and now we can make heart cells from them. Or we can make pancreatic cells if they have a if they have a insulin diabetic kind of problem, or a variety of other cells. This work was so powerful that 6 years later, 2012, Shinya Yamanaka won the Nobel Prize, and the technique is used worldwide now. And the second technique that will coordinate with that is CRISPR-Cas9. And this work was first developed by Emmanuel Charpentier and Jennifer Doudna, who worked together collaboratively. And then with subsequent work by Feng Shuang at MIT, they developed this really powerful technique that has the ability to transform someone's life and to not only detect but prevent genetic-based illnesses. The work is so powerful that most of us feel that they will win collectively the Nobel Prize. Now, what exactly is it? Well, CRISPR-Cas9 they discovered it in bacteria, and it has the ability to cut DNA. And it can cut DNA in a very precise way. But the real question is, how can it get to the right place? Oh my God. A little embarrassed about this, but this is my desk at SFU. It's been a tough semester, trust me, really tough. Those kids are getting tougher every year. Just think of my desk as your genome. Okay, take away the pistachio shells and the matcha latte stains, and then I think it becomes closer, but perhaps I have 20,000 books and leaflets on here, which represent over the 20,000 genes in your genome. And it turns out that there's a manuscript in there which runs the ethical program for this individual. And within that ethical program, there's perhaps 10 commandments. And they made a typo, and it says, "Thou shalt not steal." It says, "Thou shalt now steal." So the W is changed to a T, or vice versa. We don't want this person becoming a chronic kleptomaniac, so we have to change this. So the idea with CRISPR-Cas is to sort through that pile of crap and get to the right booklet, to the right page, to the right paragraph, to the right word, and cut it exactly so we can remove the W and put in a T. It's a horrendous task. In fact, there's probably a few grad students, skeletons are lining in here too. It's a disaster. Anyway, the experimenter in CRISPR-Cas9 has the ability to do exactly that with the guide RNA, and that's shown in yellow here. That's what directs it to the appropriate place within this massive genome of 20,000 genes and specific places within those. So once we're there, we've brought this huge machinery, the Cas9, to the right place. We can make the cut. Then we can replace the W with a T, and now it says, thou shalt not steal. Of course, this applies to the other commandments too, but I thought I'd stick with just the steal. I thought I'd leave killing and adultery out of it for now. So we have a very powerful technique in which we can go in and precisely change the genotype. And this allows us to both study diseases and to cure diseases. So how do these tools actually address the original question I raised of sudden cardiac arrest? Well, what we do in our lab is that we can take blood from a patient who has an arrhythmia. The cardiologists really aren't sure how serious this arrhythmia is, whether it could cause sudden cardiac arrest or whether they could lead a normal life. And so we can take blood from them, and people in my lab use the Yamanaka program to convert those blood cells into stem cells. And then we can use the CRISPR-Cas9, and we can either take out that mutation that we think might be causal, or we can introduce the mutation from a healthy donor and see if it causes a problem. And then we can differentiate these or change these stem cells into beating heart cells. So I was very fortunate to have a grad student somehow appear out of the blue from Iran by the name of Sanam Shafat Talab, and she worked with us and with some colleagues in Japan and developed this technique in which we drew blood from a patient. And what's shown here is actually cells that are grown in a 35 millimeter Petri dish, in a dish this size. And in a dish this size, we have tens of thousands of cells. So these cells, these blood cells, are reprogrammed through the Yamanaka technique. And then if they're CRISPR'd or whatever at that stage, that's fine. And then she starts the process of differentiating these things into heart cells. And it takes about 10 days. We have to apply chemicals to turn on certain genes, turn off certain genes. So starts at day 0. By the 10th day, the whole Petri dish is beating in unison. They're all cardiac cells. And not only that, but they're carrying the genome of the patient from whom we took the original cells. So this is fantastic work by Sanam, but then we had to ask the question, how do we really know whether the excitation is abnormal or if it's perfectly normal? And Sanam, who's shown here, she's the one with the long hair, worked with another person in my lab, very talented postdoctoral fellow, or is he an Acrobat document? I'm not sure. He's a PDF. And Eric worked with Sanam to develop something that we call an optical mapping system, and we could look at this plate of cells and actually analyze the electrical activity and see whether it's abnormal or not abnormal. And so we're able to look at specific regions of interest or dots and look at the excitation pattern. Furthermore, we're able to look at how the excitation was conducted across the plate, because this is one of the real problems that causes arrhythmias. The conduction across the heart can be abnormal. And so we see something like this. So these two work tremendously well together to develop these techniques, as well as other people in my lab and other labs. Again, a transformative set of techniques which has shifted medicine and the study of sudden cardiac arrest. So what we have here is called a disease in a dish approach. And first of all, not only is it human, but it is also of the genotype of the individual from whom the cells were taken, and it can be modified in any way we wish. And secondly, there's no animals. So there's no ethical issues about dealing with animals, nor is the more controversial scientific issue that these animals really don't replicate the human condition very well at all. But once we have that plate, the one I just showed you of 10,000 cells or so, we can interrogate that dish. And it's not like you put a hot spotlight over it and a detective comes in and plays good cop, bad cop. But we interrogated on a molecular level and challenged these cells. And we can challenge them by stimulating them electrically, by putting compounds on, like adrenaline, et cetera, and see how serious is this arrhythmia. What conditions produce the arrhythmia, and are there treatments that we can use to prevent it? And so eventually, what will happen in this field is a cardiologist will recommend a patient to us. We will go through this interrogation and then tell the cardiologist, we think this person may be at risk, and these are the best course of treatments based on our in vitro analysis. This is a far cry from what we're doing today, in which it's really hit or miss. Now, just slightly change the topic. I've been talking about 20-year-olds in the peak or the prime of their lives, but most of us are aware of sudden infant death syndrome. You hear about it a lot. And people that work in the field of cardiology are also aware that maybe up to 30% of infants that die from SIDS actually have sudden cardiac arrest. But it really never dawned on me the importance or the impact of this until a grad student came to my office by the name of Laura Dewar. And she knocked at my door and said she wanted to do a PhD. And this woman was almost 50 years of age. And I'm not an ageist, obviously, look at me. But the fact that she wanted to commit herself to doing a PhD at that stage of her life was most impressive. I had to hear her story. I had to hear why she was so devoted. It turns out she'd been a coroner in BC for more than 20 years. She had investigated hundreds of cases of SIDS, or sudden infant death syndrome, and more often than not, she had to go to the parents and say, your child died, but we have no idea why they died. It's tragic. It's tough enough for the parents to deal with the death of a child, an infant in particular, but it's even worse when you don't know the cause, because your other siblings may be at risk. Or you might think, and many parents do, that they're guilty. They did something that caused the death. So Laura went through this with me and decided we're going to do a PhD. And so what we did was we worked with a colleague by the name of Ryan Morin, and Laura knew many medical examiners across the country. And Manitoba, the medical examiner in Manitoba, had 191 cases of SIDS in which they had no known cause of death. These children had been through thorough autopsies, toxicology screens, completely negative. And they asked us, can you find any obvious cases of sudden cardiac arrest from the tissues? Challenging question. And so we sequenced all of these tissues, a massive undertaking, and we found that we had many mutations which were highly suggestive, but one in particular I'm showing right here, R37C, was particularly impressing on us because 10 of the 191 infants died of it, identical mutation. So the question is, how can you find out whether that was actually the cause of death? And this is where we brought Sanam in again, and we used the two techniques I just talked about. We used the stem cells, we CRISPR'd in this mutation into these cells, we made heart cells, and this is how they beat. They beat like this, and under normal conditions, things look pretty reasonable. But when we challenge these cells, then we see electrical chaos. And we're pretty well convinced that this work is telling us, and the cardiologists, and the parents, how their children died. And now we can look at potentially other family members who might have the same mutation. So this is transforming the field. Now, in terms of the shift, the personal shift that I felt was the death of a football player, star kid who came from Austria, had a dream. It changed how I thought about sudden cardiac arrest in elite athletes. And then Laura talking to me about trying to explain SIDS and sudden cardiac arrest in infants. But the field of medicine is undergoing a revolution. We're going from one-size-fits-all medicine into personalized medicine and eventually into precision medicine. Huge change. We're not just considering your gender or your weight or your ethnicity, but your precise genome and much more information than that. drug discovery. So currently when drugs are being evaluated, hundreds of thousands of patients are being, or tens of thousands of patients are being used in phase 3 clinical trials. This will now move into the kind of preparation that I talked about. We'll be studying it in Petri dishes before it goes to the patients, because in these phase 3 clinical trials, many patients die. And some studies have to be stopped because too many patients die. So this will revolutionize how we approach it. And regenerative medicine, we can make cornea now from the patients. Pancreatic cells are being used to treat people with type 1 diabetes. And in the future, we will be making hearts from the blood of patients. And just in the case of sudden cardiac arrest, we're going to be able to really, and we're close to doing this now, assess the degree of risk that they're at and actually make useful and meaningful interventions. And my hope is that we could really reduce the incidence of sudden infant death caused by sudden cardiac arrest. I hope you can appreciate these ideas. Remember, there's always caveats and some concerns, but this revolution in medicine is truly awe-inspiring. Thank you.